This is Module 4, Part 1B. In this section, I'll continue the discussion of diagnosis of mental illness with an emphasis on common psychiatric disorders in addition to the schizophrenia previously discussed. The next major category of mental illness that I'll discuss is called mood disorders. Mood disorders involve two abnormalities of mood: depression and mania. Mood disorders that involve the occurrence of episodes of mania symptoms usually also have episodes of depression, and they're referred to as bipolar disorders. Conversely, depressive disorders involve the occurrence of episodes of depression but no episodes of mania.
Hello, and welcome to The Answered Patient. I'm Jane Hansen. Bipolar disorder is a complex and sometimes devastating mental illness. It's characterized by extreme mood swings, which is why the disease was once known as manic depression. Today, nearly 6 million American adults suffer from the condition. In this episode of The Answered Patient, we'll discuss the risk factors for bipolar disorder, the symptoms to look out for, and the latest treatments available. Bipolar disorder is chronic, incurable, and can be life-threatening. Nearly 1 in 5 commit suicide. But bipolar disorder can be controlled. Many of the world's most creative and successful people are living with this illness every day.
A combination of medications and good psychosocial services can mean that somebody with bipolar disorder has a tremendous shot at having really quite a normal, regular life.
People living with bipolar disorder experience dramatic shifts in mood, energy, and thought.
I just felt like my head was spinning.
You feel the need to go out and achieve and conquer, but you're not in control of yourself.
You're sinking. You have to wait till you've hit the bottom of the darkest pit of your life.
The word bipolar means two opposites, which refers to these extreme mood swings from energized mania to deep depression. These moods have no pattern. They may come and go suddenly, and single episodes of mania or depression can last for months or even years.
Bipolar disorder is a cyclical disorder where it's really only a matter of time until another episode hits.
During so-called manic episodes, people say they feel important and energized.
You're not in control of yourself. Spending money that you don't have, putting yourself deep into debt.
I had racing thoughts, delusions of grandeur.
You're talking so fast, you're very tangential. People don't understand what you're talking about.
Symptoms of mania can also include elevated sex drive, substance abuse, hostility, and reckless, impulsive behavior. If the episodes are severe, patients may even experience hallucinations and delusions. When bipolar mood episodes cycle to depression, people often feel overwhelming sadness and debilitating despair.
It's like you're under a rock and you can't get out of it, and maybe you don't even want to. Because what's the point?
The symptoms of depression include loss of energy, changes in sleep and eating patterns, and thoughts of suicide. And while these symptoms can be overwhelming, nearly half of those suffering from bipolar disorder do not get the medical care they need.
That was the event that triggered it.
If you or someone you know is experiencing any of the symptoms of bipolar disorder, it's important to seek medical attention before a major crisis develops.
A lot of patients will come in and tell me, well, you know, this is not like a medical disease, it doesn't kill you. But in fact, if untreated, it can kill you.
On a night when I made the decision to commit the act of suicide, I thought long and hard about the decision I had just made. And it was only while planning the details that I decided this is wrong.
There are several types of bipolar disorder classified in a continuum from mild to severe. The two major types are bipolar 1, the most severe form of the illness, and bipolar 2, which is milder.
Nobody's bipolar disorder is just like the next person's. You know, the intensity of symptoms, the cycling of symptoms looks really different from person to person.
Bipolar disorder affects men and women of every race, age, and economic class. And while no one knows the exact cause of the illness, researchers have identified several contributing factors. Studies show that bipolar disorder, like other depressive illnesses, can result from abnormally functioning neurotransmitters, which are chemical messengers that help regulate mood. And since the illness often runs in families, scientists believe there is also a strong genetic link. Still, some people with the genes may never develop the illness. Researchers suspect it takes a combination of biological, genetic, and environmental factors to trigger bipolar episodes.
If you have a very strong genetic predisposition to bipolar disorder, you could have the most idyllic life in the world and you still may get sick. If you have a very weak predisposition to bipolar disorder, you may have to have a lot of stressors in your life to really cause this disease to kick in.
While there is no known cure for bipolar disorder, a combination of medication, psychotherapy, and lifestyle changes can help those with this illness live full, productive lives.
The video did a nice job of presenting an overview of bipolar disorders. Let me just highlight some of what was said. The bipolar disorder individual experiences episodes of manic symptoms and usually also episodes of depression. Bipolar used to be called manic depression because it involves those two opposites of that mania or high and then that very low depression in some sort of cycles. Bipolar disorder is often severe and it is a persistent mental disorder. The extreme mood states make it hard for people to maintain relationships and jobs, and at times the illness makes it difficult for someone to take care of themselves. To be diagnosed with bipolar disorder, the person has to have experienced at least one manic episode or a combination of manic and depressive in the same cycle. A person with bipolar 1 disorder may or may not have experienced episodes of depression. Bipolar 1 symptoms are more severe than bipolar 2. In the manic phase, there's a very distinct period of time. It's usually a week, or it could last as long as a year. And during that time, the person's mood is abnormally and persistently elevated, expansive, or irritable. The mood change is severe enough to cause marked impairments in occupational or social functioning. During a manic episode, a person's mood may change rapidly. Among these moods, such as alternating between that euphoria and irritability. In general, the mood is described as being so unnaturally energetic or active that harmful consequences occur. Manic episodes usually begin suddenly with a rapid escalation of symptoms over a few days. And like I said, they can last from a few days to months or longer. A manic episode is characterized by a simultaneous occurrence of this expansive mood, usually described as cheerful or energetic, and at least 3 of the following symptoms. That inflated ego that one of the patients or clients described, where they may have a range from uncritical self-confidence to those delusions of grandeur or their ability to just be invincible or have superpowers. They could also have a decreased need for sleep, and this is generally found in most of the situations with this disorder where an individual could range from getting by with just a few hours of sleep to going days without sleep and have no apparent decrease in their energy level. There's that pressured speech, which is loud, rapid, and difficult to interpret. Flights of ideas, where there's evidenced by continuous flow of rapid speech with abrupt changes from topic to topic. And when it's severe, the speech is disorganized or incoherent. Distractibility is a common symptom indicated by a tendency to respond to irrelevant external stimuli, which results in rapid changes in speech or activity. Increased activity level, where the person begins or plans to begin multiple activities, and these activities are usually accompanied by unwarranted optimism as far as how successful they'll be. And also, again, it was in the video, that excessive involvement in risky behaviors. There's a lack of judgment along with increased activity level, and this can lead to activities such as giving away the money or spending or gambling sprees, that indiscriminate sexual behavior, or reckless driving. I'll talk a lot more about the depressive side of the bipolar disorder in the section on depression and depressive disorders. Like schizophrenia, the ideal treatment for bipolar 1 disorder involves a combination of medication and behavioral intervention. The type of medications that are usually used to treat bipolar disorders are called mood stabilizers, like lithium or valproic acid. Some of the newer atypical antipsychotic medications used to treat schizophrenia have also been found to be beneficial for people with bipolar disorders. Also similar to schizophrenia, the behavioral interventions like coping skill training, ACT, and behavior management are beneficial. When somebody is very manic, the recommended approach for medication to stabilize mood and modification of the behavior of the environment to ensure the person's safety and reduce triggers of irritability or other undesired behaviors. During a manic phase, a person may say or do something that seems rude, but nonetheless it is critical to remain patient and professional at all times. When the person's mood has been stabilized to some degree, it's valuable to engage in coping skill training. At this time, that person is often able to identify effective coping strategies like taking their medication regularly and keeping to a regular routine and dealing with other problems like financing or housing. There's some evidence that keeping that regular routine can help prevent manic episodes. If they can have a schedule for sleeping and waking at a usual time, eating meals at a consistent time, and having other activities on a regular schedule, these things seem to help. It's also beneficial to help that person identify red flags or signs that they are becoming manic or depressed, and then to develop a plan on how to address those signs. Depression can be categorized into two types, either situational, that is, it's temporary and usually caused by an event like the loss of a loved one, and it is resolved when situations return to normal, or clinical depression, which is more enduring and or recurring and requires treatment. It's not triggered by an external event like what I just talked about. This would be where the category of bipolar depression would fall into this clinical category. Major depressive disorder, or major depression, is evidenced by episodes of major depression with no manic, mixed, or hypomanic episodes. Many people with major depression are able to remain in the community and benefit from outpatient treatment. For some people, however, depression is so severe that they need the supervision and support of an ALF to care for them and prevent them from attempting suicide. It is critical to connect these individuals to helplines and other supports so that they have options to reach out for help. To meet criteria for an episode of major depressive disorder, the person must have five or more of the following symptoms. The 5 symptoms must last for most of the day, nearly every day, for at least 2 weeks. At least one of the 5 symptoms must be depressed mood or loss of the ability to feel pleasure. This means a person can be depressed without feeling sad or down. The symptoms include depressed mood, which involves feeling sad, down, or blue, and the person may cry often, more often than usual. Loss of ability to feel pleasure. The person no longer enjoys activities that they normally enjoyed. This person is not interested in engaging in activities that they used to do. Change in appetite can move in 2 directions. The person may no longer eat meals with the same enjoyment, have an aversion to eating, or even lose weight. Or the opposite may occur, where the person has a compulsive need for eating and eats more than usual and gains weight. Sleep disturbance, similar to appetite, there's a change in sleep that can move in 2 directions. The person may have difficulty going to sleep, staying asleep, or may wake up earlier than usual and sleep is not restful, or the opposite may occur where the person may sleep a lot more than usual. Another symptom possibility is psychomotor agitation or retardation. Again, this change can move in opposite directions. The person with psychomotor agitation is visibly agitated, moves around more than usual, and is perhaps described as jittery. Psychomotor retardation is the opposite and involves moving or speaking much more slowly than usual. There's fatigue or loss of energy, in which the person tires more easily than usual or feels a lack of energy. Feelings of worthlessness or excessive or inappropriate guilt, where the person feels worthless most of the time and may feel excessively guilty about things that's done or not done. The person is likely to focus selectively on errors or mistakes. Difficulty thinking, concentrating, or making decisions. This person has a difficult time thinking or concentrating on daily activities like reading or watching TV. Decision making is slowed, and the person may see themselves as incapable of making decisions. Recurrent thoughts of death, suicidal ideation, or suicide attempt or specific plan. The person may be preoccupied with thoughts of death, may not care whether they live or die, or may actually wish to die. The person may have a specific plan for committing suicide or may even attempt suicide.
Depression is very hard to describe. It's not so much a thing as a lack of. It's like a dark cave, devoid of feeling, devoid of light, nothing to look forward to. It's a horrible state of non-existence. You can see a sore, a break, a cut, but you don't see mental illness. You only react to it. You see what they do, and it's bizarre and ridiculous and at times funny.
Depression can begin at any time in a person's life, including childhood. Across people, there is a lot of variety in terms of how severe the symptoms are, how long an episode can last, or how many episodes people have over their lifetime. Most people have their first episode early in their life, such as childhood, adolescence, or early adulthood. Similar to other disorders, major depressive disorder has a complex mix of biological and environmental causes. There is a genetic component in addition to neurochemical changes in the brain. Conversely, there is also very long evidence that stressful life events can cause depressive episodes, such as the death of a loved one, divorce or separation, a job loss or other financial problems, health problems, or a traumatic event. It's normal to have a period of distress or mourning when these events occur. Depression is diagnosed when the reaction to stressful life events is severe or prolonged. Some people are able to bounce back, whereas other people remain stuck and become depressed. The stress diathesis theory suggests that some people are vulnerable to becoming depressed after a stressful life event because of their genetics, brain chemistry, personality, limited social support, and limited problem-solving and coping skills. For most people, 70 to 80%, depression is effectively treated with antidepressant medications or psychotherapy. There are several categories of antidepressant medications that work well, including the triglyceric, or the older ones, and selective serotonin reuptake inhibitors, SSRIs, with common commercial names such as Prozac or Paxil. Several forms of psychotherapy work just as well as medication in many cases, including cognitive behavioral therapy, interpersonal therapy, and problem-solving therapy. In general, medications and therapy work equally well. If someone is very severely depressed, then combining medications and therapy is recommended. If someone is very severely depressed and medication or therapy has not worked, then electroconvulsive therapy, ECT, can be effective.
From time to time, everyone feels sad or blue. It's a normal reaction to disappointment or loss. But when those feelings persist, preventing a person from leading an active and healthy life, depression might be the cause. This complex and often debilitating illness is much more prevalent than you might think, but it can still be difficult to diagnose. When determining whether a person is suffering from depression, doctors look for several key symptoms. These include loss of interest in pleasurable activities, persistent sadness, feelings of hopelessness or irritability, difficulty concentrating, and insomnia.
When we try to define depression, we think about three different kinds of symptoms. The first are what we call symptoms of mood, and those are the things that most people think of when they think about depression. Those are things like sadness, tearfulness, feeling discouraged.
You feel absolutely helpless and hopeless. It is simply inconceivable that life will ever get better.
The second kind of symptoms are what we call vegetative symptoms of depression. That's how depression affects your appetite, usually either eating too little or too much, sleeping too little or too much, and lethargy, feeling tired and kind of worn out. And then the third kind are what we call cognitive symptoms, and that's how depression affects our thinking. That's having low self-esteem and negative thinking, feeling pessimistic about the future, and also suicidal.
When I was at my worst,
and I would lie in bed and not move and not do anything. I'll be almost catatonic.
Unfortunately, there are no clinical tests that can definitively show whether a person is suffering from depression. Instead, your doctor will begin by conducting a physical exam and possibly ordering blood tests and brain scans. These procedures will look for other potential causes of the symptoms, such as certain prescription drugs, viral infections, or other medical conditions.
For example, your thyroid hormones are too low, or you're anemic, or you have some other signs or symptoms that just don't seem to fit and would suggest that there's another medical illness going on.
Once other causes have been ruled out, your doctor might refer you to a mental health specialist for a psychological evaluation. Psychologists and psychiatrists sometimes use questionnaires or self-assessment tests to help diagnose depression. These tests measure a person's relative outlook on his or her life, as well as the severity of the symptoms they're experiencing.
It's a really short measure. It takes 5 to 10 minutes to fill out, and it includes things like appetite and sleep, whether or not you're feeling sad or tearful or suicidal.
One of the best ways for your doctor to determine whether you are suffering from a mental illness is simply to talk to you. Your doctor will want to know when your symptoms began. If they've lasted for more than 2 weeks, it could be a sign of what's known as major depression. Your doctor will also ask you about the specific nature of your symptoms and their severity. Symptoms vary widely from person to person, as well as by age and gender. In addition to looking out for and evaluating symptoms, the psychiatrist or psychologist will also inquire about 3 contributing factors for depression: biological, genetic, and environmental. Over the last 50 years, scientists have come to place greater importance on the role biology plays in the occurrence of depression. Research has indicated that people who suffer from depression tend to have improperly functioning neurotransmitters, the chemicals that allow brain cells to communicate with one another. Antidepressant medications have been shown to help curb depression by altering the levels of these neurotransmitters.
What we know about these neurotransmitters as they relate to depression is that this is how most of the antidepressants appear to work. They will, in various ways, raise levels of serotonin, norepinephrine, or both of them. And so far, that's pretty much true of almost all of the antidepressants we have.
Scientists have also found a relationship between depression and hormone regulation, especially in women.
We know, for instance, that hormonal functioning affects the presence of depression in women. Where do we see that? Well, we see that often connected with a woman's menstrual cycle.
These hormonal changes are particularly evident around childbirth. As many as 80% of women experience temporary feelings of sadness, irritability, and insomnia shortly after delivery, a condition commonly known as the baby blues. In some cases, however, the symptoms persist, triggering a more serious type of depression known as postpartum depression, a condition that affects as many as 1 in 10 women. Research has also indicated a strong genetic link to depression. Someone with an immediate family member who has suffered from depression is at a higher risk of developing the illness. In fact, some studies indicate that up to 50% of those with a type of depression known as bipolar disorder have had at least one parent with the disease. However, doctors stress that genetics alone aren't necessarily enough to trigger depression.
People might inherit what we call a vulnerability for depression, and then there's something in the environment that kicks that off. So you may have a vulnerability for depression, but if you don't have any of these psychosocial stressors, you may never have depression in your lifetime.
These environmental factors are the third dynamic that can trigger the onset of depression. A major event, even a happy one, can cause a depressive episode, so can a change in season, a divorce, or the loss of a loved one. Depression can also be caused by physical, sexual, or emotional abuse. Coexisting illnesses or substance abuse may also play a role in depression.
Anxiety disorders involve the presence of symptoms of anxiety and/or avoidance behavior. The main difference across the different anxiety disorders are determined by what is feared and how the person tries to avoid it. Although there are several specific diagnoses, anxiety disorder can be grouped into 5 categories, as I'll talk about in a minute, and I'll summarize each on the following slide. Panic disorder, phobic disorder, obsessive compulsive disorder, post-traumatic stress disorder, and generalized anxiety disorder. Panic disorders involve recurrent panic attacks. A panic attack is an abrupt episode of intense fear with associated intense automatic arousal, such as shortness of breath, dizziness, rapid heart rate, trembling, sweating, choking, nausea, or chest pain. These attacks are usually unexpected and last for several minutes, rarely hours. In the beginning, they're not associated with any particular stressful situation. They are followed by persistent concern about the attacks. Over time, the person fears having additional panic attacks, which can lead them to avoid situations where they had the panic attacks in the past. Panic disorder can lead to agoraphobia, which may include becoming unable to leave a confined or safe setting. Phobic disorders involve experiencing intense, excessive, or unreasonable fear associated with a particular situation or stimulus. Common types of phobic disorders include the agoraphobia, which is a fear of situations in which escape is difficult or embarrassing, generally because of the fear of the panic attack. Social phobia, which is a fear of interpersonal or social situations like public speaking, large social gatherings, dates, eating in public. And specific phobia, fear of a specific situation or object, like heights, flying, or snakes. Phobic disorders also involve avoidance behavior. That is, the person tries to avoid fear objects or situations. To be diagnosed with a phobic disorder, the avoidance must be distressing or result in significant impairment in the person's social and occupational functioning. For example, a person with social phobia may have difficulty keeping a job or developing close relationships. A person with phobia of heights may have difficulty going to many places, which severely limits their mobility. With obsessive compulsive disorder, it involves obsessions or compulsions that are distressing or interfere with the person's social and occupational functioning. Obsessions are recurrent, unwanted thoughts that are usually experienced as intrusive or senseless. Among the most common obsessions are recurrent thoughts of contamination by germ, dirt, or chemicals, or fear of losing control, such as acting on an impulse to hurt someone else. Compulsions are repetitive, intentional behaviors that are performed to avoid the obsession and decrease anxiety. This could include repetitive hand washing to the point that your skin breaks down in response to the obsession with contamination. When the person attempts to resist a compulsion, they experience increased anxiety, which is promptly relieved by carrying out the compulsion, at least for a short time, and then the compulsion returns and the cycle repeats itself. With post-traumatic stress disorder, PTSD, this has received a lot of attention because of its prevalence among veterans. PTSD develops after an extreme traumatic stressor like combat, a serious automobile accident, or violent crime. Such an event would be distressing to anyone and is usually experienced with intense fear and helplessness. Therefore, PTSD is diagnosed when the reaction to the traumatic event is severe and prolonged. The major symptoms of PTSD involve re-experiencing the event, flashbacks and recurrent nightmares, avoidance of stimuli or situations associated with the event, and increased arousal. This includes difficulty falling asleep or staying asleep, recurrent nightmares about the event, hypervigilance, and exaggerated startle response. Generalized anxiety disorder involves excessive anxiety and worrying that occurs more days than not over a period of 6 months or longer. The person must worry about multiple life domains like finance, health, relationships, family members' well-being, and have difficulty controlling these present worries.
Hello and welcome to The Answered Patient. I'm Jane Hansen. In this episode, you'll learn about anxiety disorders, some of their symptoms, how they're diagnosed, and the treatment options that are currently available. We all know that modern life can be stressful. Balancing the demands of our family and work lives can often cause feelings of stress and anxiety as we try to do all that we need to. And for most people, anxiety about deadlines or social situations is normal. But for people suffering from an anxiety disorder, this sense of nervousness is chronic, lasting for 6 months or more. These feelings can be overpowering and are often out of proportion with reality.
Anxiety disorders are the most common mental health problem affecting adults in the U.S.
In our country, we spend $47 billion a year taking care of patients that have anxiety. And that includes pharmaceutical support, psychotherapy, medical visits, and so on. And it also includes the economic aspect of lost wages.
While the exact cause of anxiety disorders is unknown, experts believe that heredity may be involved. Environment, personal development, even your diet may play a role in whether you have an anxiety disorder. So what is anxiety? In part, it's a physiological response to a stressful situation. It's related to the so-called fight or flight response. When faced with a dangerous situation, anxiety can be a useful tool to help us anticipate trouble, spurring us into action, and keeping us out of harm's way. In dangerous or frightening situations, our heart rate goes up, blood flow to the heart and muscles increases, and production of the hormone adrenaline rises. Under normal circumstances, when the danger passes, the physical responses and the heightened feelings of fear and stress that go along with them will pass too. But with an anxiety disorder, these feelings and physical symptoms are persistent and interfere with everyday life.
It's a normal emotion. There are countless situations where anxiety is appropriate and a good thing. If you're walking down a dark street and you hear somebody walking behind you, you want to be vigilant.
When it's interfering with your day to the point that you're unable to get basic needs completed, basic job functions done, school things that you need to do completed because all you're doing is worrying about it, then it's a problem.
There are 5 types of anxiety disorders. Each is usually diagnosed by its symptoms. There's generalized anxiety disorder, obsessive-compulsive disorder, post-traumatic stress disorder, panic disorder, and social phobia, also called social anxiety disorder. Generalized anxiety disorder, or GAD, is one of the more common forms of anxiety disorders. GAD affects nearly 7 million people in the U.S. alone. It can begin at any age, but many people develop GAD in childhood or early adolescence. Women are twice as likely as men to develop this form of anxiety. As the name suggests, worries for people with generalized anxiety disorder tend to be general and are often related to everyday life. Obsessive-compulsive disorder, or OCD, is a second type of anxiety disorder. In this disorder, a person persistently experiences troubling thoughts or obsessions, which lead to rituals or compulsions that are used to try to control those thoughts. For example, someone with OCD may feel the need to perform certain acts, like locking a door, in a certain sequence, Or they may also do things repetitively. These rituals may temporarily keep the obsessive thoughts at bay, but many people with OCD are fully aware of their habits and are troubled by them.
Obsessions are intrusive, unwanted, repetitive. The individual sees them typically as senseless. They don't seem to jibe with who they are as a person.
An anxiety disorder can also develop following a particularly stressful or traumatic event. This type of anxiety is called post-traumatic stress disorder. It often develops after an event in which a person has experienced the threat of physical harm or has actually been hurt. People suffering from post-traumatic stress disorder may be emotionally numb or may startle more easily. They may lose interest in activities they used to enjoy. Flashbacks or thoughts and memories about the event are common and tend to be persistent. A person with panic disorder typically experiences a rush of panic, which can involve a sudden feeling of terror along with very frightening physical responses, such as rapid heartbeat, sweating palms, and dizziness. During a panic attack, a person may feel as if they're having a heart attack. Social phobia, also called social anxiety disorder, is an intense fear of everyday social interactions. A person with social phobia may feel that they are being watched and judged by others, or they may experience intense dread about an upcoming social situation, sometimes worrying over it for weeks in advance. Much has been learned in recent years about why anxiety disorders develop and how they can best be treated. For many, a combination of psychotherapy and prescription drugs can help keep these conditions under control. As with any condition, talk to your doctor if you think you may be suffering from an anxiety disorder. He or she can work with you to find the best treatment.
Anxiety is not a fear of a thing. It's really a fear of the way we think about a thing.
It is something that can be easily treated and something that has a great outcome if the medications work and therapy helps and it's possible to get better.
The video did a good job of summarizing anxiety disorders. As mentioned, anxiety disorders are some of the more common psychiatric illnesses, and they affect approximately 25 to 30% of adults. These anxiety disorders do often begin in adolescence or early adulthood, and if left untreated, they tend to last for years for many people. People with anxiety disorders commonly have major depression as well, and in these cases the anxiety usually begins before the depression. As with all other disorders, anxiety disorder appears to be caused by a combination of biological or genetic issues, psychological, personality and coping styles, and environmental factors, stress, or traumatic life events. Most anxiety disorders, except for OCD, are more common among women. Certain fears, like social situations or animals, may be learned from one's family or others, like authority figures. Anxiety disorders are commonly treated with medication. Antidepressants are also effective in some anxiety disorders, and are medications like alprazolam are used during times of an acute anxiety attack. Evidence suggests, however, that psychotherapy is more effective in the long run for treating an anxiety disorder. The form of psychotherapy with the strongest evidence of improving or addressing anxiety disorders is called cognitive behavioral therapy, in which the therapist teaches the person relaxation skills and helps the individual to gradually stop avoiding and confront feared stimuli. Personality disorders are very difficult to change and treat, although psychiatric medications and psychotherapy can be beneficial, as well as use of behavioral management strategies to identify triggers of problematic behavior and to reward desired behaviors. The person may be critical of you or others, overly flattering, or they may vacillate back and forth. Simply remain patient and professional with them. Personality disorders begin early in life. They involve long-lasting patterns of perceiving, relating to, and thinking about the environment, oneself, and other people. People with this illness exhibit problems in interpersonal relationships. Personality disorders are briefly described in this section because individuals with personality disorders can create challenges for staff and others. The major manifestations of the various personality disorders include the following. I'll briefly describe them. Antisocial personality disorder, also called sociopathic or psychopathic personality disorder. People with antisocial personality disorder are often in trouble. Their behaviors include criminality, assaultiveness, impulsivity, stealing, lying, promiscuity, unreliability, and severe drug or alcohol problems. Although they are adept at social interaction, they often fail at jobs, are abusive to family members, and cannot maintain close relationships. The behavior seems to peak in late adolescence and young adulthood and is more common in males than females. Borderline personality disorder, or BPD, is complicated. Usually people with BPD are socially functional, but they can become transiently psychotic and or depressed. Common clinical characteristics include intense and highly variable emotions, especially anger, anxiety, chronic loneliness, boredom, a sense of emptiness, volatile interpersonal relationships, and impulsivity. Persons with BPD tend to alienate staff, and they may play staff members against one another. Suicidal threats and gestures are common. Histrionic personality disorder is a pattern of excessive emotionality and attention seeking. Narcissistic personality disorder is a pattern of grandiosity, a need for admiration, and a lack of empathy. Continuing, avoidant personality disorder is a pattern of social inhibition, feelings of inadequacy, and hypersensitivity towards negative evaluation. Dependent personality disorder is a pattern of submissiveness and clinging behavior related to an excessive need to be taken care of. Obsessive compulsive personality disorder involves extreme perfectionism that usually interferes with the ability to carry out a task. Obsessive compulsiveness involves an adjustment that is inhibited, perfectionistic, judgmental, rigid, continuously anxious, and detached from intimacy, very demanding on oneself. Paranoid personality disorder is a pervasive and unwarranted tendency to interpret the actions of others as deliberately demeaning or threatening. Someone with this disorder perceives others as out to get them. Their own suspicions and mistrust are barriers to their seeking or accepting treatment. For a complete list of personality disorders and their traits, see the DSM-5, the Diagnostic and Statistical Manual of Mental Disorders.
The obsessive compulsive behavior, it's like a calling, you know? Like I can be walking and see a drop of water on the counter and have to scrub the whole kitchen. It's like a tap on your shoulder that you should go do this right now. Summoned is the word, because you have to do it right now.
Let's talk about cognitive disorders now. They refer to a category of disorders that cause deficits to memory and or other aspects of cognitive functioning like attention, processing speed, and language. Two common categories of cognitive disorder are delirium and dementia. These are not specific medical diseases, but sets of symptoms or syndromes that can have various underlying medical causes. Delirium is a syndrome or a set of symptoms that's characterized by a reduced level of consciousness, sensory misperceptions, disturbance of sleep-wake cycle, disorientation, and memory impairment. This syndrome also involves a reduced ability to maintain or to appropriately shift attention and disorganized thinking, as exampled by rambling or incoherent speech. The onset of delirium is usually rapid, and the duration is brief if it's treated properly. Symptoms typically fluctuate in intensity. Depending on the underlying cause, the delirium could cause death or irreversible brain damage if it's not treated in a timely manner. A variety of underlying physical conditions like a severe infection, stroke, or other head trauma, a severe electrolyte imbalance, or alcohol withdrawal can cause delirium. Even young children and older adults, particularly people with physical health problems, are at a heightened risk of delirium. Delirium represents a major medical emergency. A person with delirium should be seen by a physician right away, and the physician should identify and treat the underlying cause of the delirium. Symptoms of dementia involve multiple cognitive deficits that impair a person's functioning and is a decline from previous functioning. Dementia impairs memory, including the ability to remember new information and the ability to recall information that was previously learned. Dementia also impairs at least one other area of cognitive functioning: language, the ability to carry out motor activities, failure to identify objects, or executive functioning, that is, reasoning, judgment, planning, and organizing. The principal difference between dementia and delirium are that the dementia typically has a slower onset, more stable symptoms, and much longer duration. The exact course of dementia depends on the underlying physical condition that's causing the dementia. Dementia may worsen or remain the same or sometimes improve depending on the underlying cause and the treatment. Most of the time, dementia is either stable or worsens. As dementia progresses, behavioral problems may occur, like wandering or agitation. People with severe dementia become disoriented, not knowing who they are, where they are, or the date. They will also often lose the ability to recognize loved ones or others with whom they have a close relationship. For example, ALF staff that they see every day may become unknown to them. Like delirium, dementia is a syndrome. Dementia is caused by several different physical diseases. Alzheimer's disease is the most common cause of dementia, and it accounts for over half of the cases of dementia. But there are other causes of dementia as well. There's arteriosclerosis, also called hardening of the arteries, vascular dementia, dementia due to medical conditions like HIV, head trauma, Parkinson's disease, Huntington disease, Pick's disease, or substance-induced. The primary risk factor for dementia is age, becoming much more common in later life. It's estimated that 2 to 4% of adults aged 65 or older have Alzheimer's disease, but this prevalence increases to almost 50% by the age of 85. Other risk factors for dementia include genetics, a family history of dementia, low education, and alcohol or substance abuse. Healthy habits, good nutrition, exercise, limited alcohol intake, and not smoking also appear to protect against some causes of dementia. The medical treatment approach for dementia depends on the cause. Therefore, if dementia is suspected, it's critical that the person receive a complete medical evaluation. For Alzheimer's disease, several medications can be used to treat cognitive impairment, such as Aricept. These medications do not cure or reverse Alzheimer's disease, but they seem to slow down the progress of the disease. Behavioral management is very effective at managing a variety of the problematic behaviors seen in ALF residents with dementia, like that wandering, agitation, or withdrawal. In cases of agitation, usually the person's being understimulated, like sitting around with nothing to do. So by making noises, someone attends to them, which is rewarding. Or they could be overstimulated with too much activity or noise and receiving complicated instructions. The use of behavioral management principles can help you to identify and eliminate some of the triggers and keep the person engaged in enjoyable and rewarding activities.
I was drinking, I went to jail, and then Wednesday I went to jail, and then yesterday I went to jail due to alcohol. And it's just like being in a haze, a blackout. But I have to do what I have to do, because if I don't self-medicate myself, then I'm going to be worse than what I am now. I'm either going to be beat down, or I'm going to beat someone else down. It's like a Dr. Jekyll, Mr. Hyde thing. That's the insanity.
Substance-related disorders include disorders related to abusing drugs, experiencing side effects of medication, and being exposed to toxins. DSM-5 has various classes of substances that can be involved in substance-related disorders. There are two broad types of disorders within the substance-related disorder category, specifically substance use disorders. On the left, this includes substance abuse and substance dependence, and substance-induced disorders. On the right, this includes intoxication, withdrawal, and substance-induced mental disorders. For substance use disorders, the substance abuse and substance dependence both involve maladaptive patterns of substance use, and this can lead to significant impairment or distress. These may involve negative consequences related to work, social relationships, legal status, physical and psychological health. In addition to the harmful consequences associated with repeated use, substance dependence also involves the experience of tolerance, or the need for increasing amounts of the drug to achieve the desired effect. Withdrawal, where symptoms experienced when the use of the drug is discontinued, and compulsive use, taking more of the drug or taking the drug more often than intended, or the persistent desire or unsuccessful efforts to cut down on the usage. The occurrence of tolerance or withdrawal symptoms indicate that the person has a physiological dependence on the drug. With regard to substance-induced disorders, a variety of mental illnesses can be induced by the substance used. For example, a person could evidence symptoms of depression that are caused by the use or abuse of the drug. In this case, the person could be diagnosed as having a substance-induced mood disorder. Disorders include mood disorder, anxiety disorder, psychotic mood disorder. persistent dementia, and delirium. Since these disorders were described previously, I'm not going to discuss them further here, except to note that the use of substances can cause or make worse the symptoms of those mental disorders. In addition to the previously described substance-induced disorders, there are two other substance-induced disorders, intoxication and withdrawal. Substance intoxication is the condition that occurs as a result of taking a drug. Withdrawal is a set of symptoms that occur when a person who is dependent on a substance discontinues the use of that substance. It's important to keep in mind that substance intoxication, particularly when the person takes an overdose, and withdrawal can be potentially life-threatening circumstances and should be taken seriously. If a person who has been abusing substances begins to show symptoms like extreme lethargy, disorientation, hallucination, or convulsions, they need immediate medical attention. The course of this disease varies depending on the substance and severity of symptoms. For example, many young adults abuse alcohol and then go on to moderate their alcohol use throughout the rest of their lives after leaving certain environments such as college. Depending on severity, substance abuse or dependence can have devastating effects for individuals, including criminal behavior, job loss, relationship loss, and other risky behaviors to obtain their substance. Individuals with long-term substance abuse or dependence will usually experience other serious physical and cognitive disorders later in life. As with the other mental illnesses, the causes are not fully understood, although there are a mix of biological, psychological, and environmental risk factors. A person's genetics and biological functioning can make him or her vulnerable to substance abuse or dependence. Exposure to substances, stressful life events, and other mental illnesses also increase the risk of substance abuse or dependence. Treatment depends on the substances that are abused in addition to the degree of dependence and severity. It may be necessary to hospitalize someone during detoxification. Outpatient treatment varies from self-help groups like Alcoholics Anonymous to formal mental health treatment like inpatient settings. Mental health treatment can involve medications that reduce cravings or other psychiatric symptoms like depression or anxiety, as well as psychotherapy to examine causes and triggers of substance abuse and improve coping skills so that folks can manage problems associated with substance misuse, like job loss or interpersonal conflicts. Behavior management principles can be useful to help identify antecedents of substance abuse and to reward desired behavior. Mental illnesses do not occur in isolation. Often an individual may be diagnosed with two or more disorders, which is called comorbidity. Another phase is co-occurring disorders, which generally refers to the comorbidity of a mental illness and a substance use disorder. For example, major depressive disorder and alcohol dependence. Comorbidity can occur at the same time or at different times, like PTSD at one age, major depression at a later age. There are several reasons why people often have two or more diagnoses. The same risk factors can cause multiple disorders. A trauma can cause PTSD and depression. One disorder can cause another. Disorder like alcohol abuse can cause depression, and depression may cause Alzheimer's disease, or the person may have two diagnoses that coincide. Comorbidity of major depressive disorder and the anxiety disorders is very common. Substance misuse is also very common in most of the other mental disorders, including schizophrenia, bipolar disorder, depression, anxiety disorder, and personality disorder. Substance misuse can lead to delirium or to dementia. Finally, mental and substance use disorders are often comorbid with other physical illnesses as well. There's some evidence that these relationships are bidirectional. Physical illnesses can cause mental illnesses, and mental illnesses also appear to lead to physical illnesses. Comorbidity can complicate treatment.
The public looks at individuals with mental illness like we're not even human. When I look at people who talk about that, they use terms like lunatic. They talk about you in the third person like you're not even in the room. And they don't want to be seen in our company. They're afraid to come near us.
Stigma is common for people with mental illnesses. The person may be afraid of what other people will think, and other people actually treat that individual differently. People often avoid living or socializing with someone with a mental disorder. Professionals and guardian advocates may hold inaccurate or prejudiced views about people with mental illnesses, or they may experience symptoms themselves. These are called secondary stigma or stigma by association. Some mistaken beliefs that cause stigma are that someone with a mental illness is violent, less intelligent, weak, or just needs to pull themselves up by their bootstraps, or that they just need to, quote, snap out of it, unquote. Stigma causes people with mental illnesses to hide their symptoms and avoid treatment. Although 1 in 5 Americans have a mental disorder, less than half of the people with a mental illness seek any kind of treatment. Being isolated or shunned by others can also worsen a disorder. To address stigma, it is important to consider personal attitudes about mental illness, the language used, and how one interacts with someone with a mental illness, and how others who interact with these individuals can potentially stigmatize them. It's important to not blame the person. Most people are doing the best that they can given their situation. On the other hand, it's important to not see that individual as helpless or that their symptoms as out of their control. They can often learn ways to manage or cope with their symptoms, and it's important to be understanding as well as trying to empower them. Language is also powerful. Using person first language, a person is not defined by their diagnosis, so they do not refer to someone as, so don't refer to someone as a schizophrenic. Instead, say a person with schizophrenia. Avoid terms like crazy or psycho. There's little reason to fear someone with a mental disorder. While some symptoms may seem odd, the vast majority of individuals with a mental illness are not violent and do not harm others. Safety considerations should be more on an individual rather than a stereotypical basis. Another myth about people with mental illnesses is that they will always have a mental disorder. With proper treatment and support from others, many people with mental illnesses recover. Even people who do not fully recover or have a recurrence still contribute to society and can engage in a meaningful relationship and activities, including work, helping others, art, and many others. This concludes Module 4, Part 1B. You may go back and review the information on diagnosis of the major mental illnesses, or you can continue on to Part 2, where we'll discuss the medications.